Good afternoon and welcome to Medications to Treat Facial Pain featuring Dr. Wolfgang Liedtke. I'm Sarah Winter, the Marketing, Communications, and Events Manager for the Facial Pain Association. We're honored to have Dr. Liedtke with us here today. Just a few housekeeping items before we get started. If you'd like to ask a question, please put it in the Q&A chat, which is on the right side of your screen. If your question is not answered during the live Q&A after the presentation, don't worry. Dr. Liedtke will answer all the questions in written form, and those answers will be available on the conference platform when the recorded sessions are available. Also, please understand that none of our presenters today can answer specific questions about your case. However, we will ask general questions most relevant to people living with facial pain. Now for a quick introduction. Dr. Wolfgang Liedtke is an executive with Regeneron Pharmaceuticals in genetic medicines in their global clinical development unit and a member of the scientific council where he's chair of neurology, psychiatry, pain medicine, and sensory systems. Before joining Regeneron in 2021, he was a tenured professor at Duke University for 17 years. He conducted basic neuroscience pain research and co-founded the Duke University Pain Research Group. He is also a member of the FPA Medical Advisory Board. You can read more about his bio in the presenter section on the homepage of the conference app. So without further ado, Dr. Liedtke.
Okay. Yeah, I'm super happy to be here, glad to be here again, because I felt that last year's presentation was met by an audience that I was very happy to present to. And so here we go again with this title, Medications to Treat Facial Pain. I'm very much looking forward to interacting with everybody. And as Sarah said, I will be taking to the questions that are not answered, and we will filter them and go through redundancies so that themes are being answered. But I will take to all issues that are being brought to my attention, which we're not able to cover in the time allowed. And so without further ado, I will move into the presentation now. One word, I'm still with Duke University as an adjunct professor. I'm also an adjunct professor of dentistry in the Department of Molecular Pathobiology and Dental Pain Research at NYU. And so both academic affiliations relate to my interest in studying pain and in treating patients with craniofacial pain and nerve pain in general. Okay, so I am a full-time executive employee with Regeneron, but what I'm talking about here is not the opinion of Regeneron, it's my own private opinion. Adjunct faculty with the two universities. I co-founded a biotechnology company that has no bearing on this talk. It's an informational overview, not medical consultation. My own insights, my own opinions, not the opinions of Regeneron, Duke, or NYU. And it's not medical measure suggestions to you, but rather informational. So who am I? I am a bipedal, so I walk on two legs. One leg is research into pain mechanisms, and one leg is caring for patients who are suffering from these forms of pain with a recent switch to the corporate environment. And I can give you a quick word on that in the next slide. But so as a clinical-based investigator, I have treated patients with craniofacial pain and nerve pain in general, as shown on the right-hand side, where you see a patient with a broken jaw and suffered an injury to the inferior alveolar nerve with horrible pain. And I'm quite proud that we were able in my clinics to give this gentleman essentially a life back, although it didn't work right on the spot. The mask you see is from a patient who was suffering an injury to the trigeminal nerve because of a blast explosion. So he was a military service member who survived an explosive blast in the Iraq war, and his trigeminal nerve got injured. which made him suffer thermal missensation, feeling a cigarette extinguished over his eyebrow, even though nothing touched him. He was just subjected to the blast airwave. And he also had emotional issues that were being worked up in our therapy. And I was helping this gentleman as well. So I became, after all, I became a curator of comorbidities in my laboratory at Duke University. We reverse translated what I learned from my patients in clinics and tried to elucidate mechanisms such as chronic temporomandibular joint pain, which we brought from patients into the laboratory mouse, and established a TMJ pain model in mice that allowed us to study this disease at a more profound level. Since 2021, I am on board Regeneron Pharmaceuticals, unique biotech pharma company, and have portfolio responsibilities in neurology, psychiatry, pain medicine. So let's get going on the topic of the talk, medications for facial pain. Let's start with what a patient would start with once facial pain hits and worsens and rears its ugly head at a level that is above the normal suffering. And we will get to that, how to deal with the normal suffering. But here we are talking about exacerbations, a worsening of pain, or outright pain attacks. So patients need to have medications to deal with these attack-like and episodic worsening of pain. And a very simple fact is that episodic pain, when treated with regular tablets, anti-pain medication in general, the anti-pain medication will be too late. So there needs to be a way to get at the attack that matches the time dynamics. The attack comes fast, so there needs to be fast-acting medications. And patients typically know when pain is coming and have a premonition, or in migraine, it's called aura and pre-aura, prodromal phase and aura, and then the migraine pain hits. And there is something like that for many patients with trigeminal pain who rarely are being hit by their pain like a flash from the sky. So during this prodromal phase, when patients know very likely the pain is coming, that's the critical time period when you need to be able to do something. And that will not happen by swallowing tablets, because they will take too long until they even start acting. So I have listed here a number of medications that are suitable for this fast-acting intervention, self-intervention that the patient can do, and not rendering to the urgent care, emergency care, etc., but at home, and the sooner the better. And so these are medications that block sodium channels, like carbamazepine and oxcarbazepine. And here the critical issue is formulation. So carbamazepine is available as a chewable medication, and oxcarbazepine is available as a liquid medication. So those can be taken into the mouth and chewed, or swish around and then swallow. There is also clonazepam, which is a benzodiazepine, diazepam-like medication that acts on trigeminal pain, whereas diazepam really does not. And it's available in a formulation of an orally dissolving tablet. And those have been found very, very effective. They're fast-acting. This is the right dose for trigeminal pain attacks, exacerbating craniofacial pain, an 1/8 to 1/4 of a milligram in the orally dissolving rapid-acting form. Gabapentin is available as a liquid. However, gabapentin is a bit slower in onset. But if a patient knows gabapentin and Lyrica are really working for them, there is liquid gabapentin. So there is now also very recent developments, medicines that have come up on the migraine, on the migraine scene, and those are the so-called gepants. And there is rimegepant and zavegepant. And rimegepant is orally dissolving tablet. and zavegepant is a nasal spray. So they will be fast acting, and they act on so-called CGRP signaling, and that has, by experimental studies, a important role in trigeminal pain. Clinical studies toward the effect of these medications are running, and anecdotal evidence from patients whom I have prescribed rimegepant, and zavegepant came after my departure from Duke, were positive. And patients liked the acute onset effects of rimegepant on trigeminal pain, were favorable of it, a safe and effective medicine. And with that, I believe it will become part of the armamentarium to deal with trigeminal pain attacks. Next, something that I have found very useful, I have prescribed a lot and experienced a great echo by my patients, is nasal spray containing ketamine, which is a medicine called Spravato. However, Spravato is very, very limited, or is limited to its use in psychiatry for treatment refractory depression. And if a patient does not have that disorder, the medicine will essentially not be approved. The very expensive medicine will not be approved by insurance carriers, and that has proven impenetrable. So I resorted to prescribing ketamine as a nasal spray made by a compounding pharmacy. And compounding pharmacies can make ketamine nasal spray at 100 to 150 milligram per ml, and per nasal puff, then it's a tenth of that. Spravato is more concentrated, but my simple hack around that was to just have the patient apply more puffs. And ketamine nasal spray is in my hands and with the patients to whom I have prescribed is excellent, and is fast acting, and it can curb an attack while it is building up, and thus prevent its manifestation. It is a compounding medication. It's not super expensive, but it is also a controlled substance. So that has to be discussed with the prescriber that is willing to prescribe ketamine nasal spray at that dose. It's not an opioid. It's a controlled substance. What is also a compounding medicine, not a controlled substance, is oxytocin nasal spray. That is super harmless, a peptide hormone that is absorbed perhaps to a level of a tenth of the dose through the nasal mucosa when using as a nasal spray. And oxytocin nasal spray has found its way into medicine through migraine, even though oxytocin nasal spray is not yet an approved medicine. So it also has to be made. It also has to be compounded. But I did highlight here the really great safety of the medicine with essentially no known disturbing or more serious adverse effects. Last but not least is lidocaine jelly, which is just numbing, and as a jelly for nasal application, for intraoral application, or as a spray to the affected area. And so lidocaine for intraoral or for nasal application, especially if the pain manifests and is triggered by these areas, that it's a trigger in the nasal passageways, or is it an intraoral trigger? That is a very distinct trigger around a particular tooth or around a particular side of the gums. Then lidocaine jelly or spray can be very suitable. Apply it early and numb the area can be very, very helpful in curbing impending attacks. So that's a list of a number of things, and it goes with try these medications out. What is the most effective to curb your attack and to be effective against attack manifestation when applied early. And there is individual variation. I have prescribed pretty much all of the above with good and convincing effects to many of my patients. So it's hard to rank them, but from practical perspective, those sodium channel blocking agents, they are inexpensive and readily prescribed. Klonopin is also readily prescribed, but it's a controlled substance as well. Here a word, they can be combined. So for example, orally dissolving klonopin and chewable carbamazepine goes together wonderfully and has helped many patients. The nasal sprays, I would say, if the pain is manifested in the second branch, then a nasal spray is perhaps really a direct avenue to go to. Ketamine is a controlled substance, but again, very effective, relatively inexpensive compounding medication. For whom oxytocin works, that's wonderful because it's so benign. Same with lidocaine. Okay, what also needs to be controlled is the upshoot in blood pressure when pain hits. It's an enormous stress. It's an enormously powerful stimulus to elevate blood pressure. Blood pressure elevating is not good for the trigeminal system, so that is something that can also be treated together with the anti-pain, the acute fast-acting anti-pain agents, so control the blood pressure as well. If a patient can get a metric of how it goes when pain comes and measure blood pressure as pain surges, that can be very helpful to estimate how bad are things. And sometimes the blood pressure is the main contributor to the impact, the high impact of the pain. Then acting against blood pressure is an imperative that should not be deprioritized. And for that, unfortunately, we don't have the variation and the spectrum of fast-acting agents as we have for pain, but we have a fastest-acting tablet, which is listed here, captopril, 25 milligram, clonidine, 0.1 milligram. They are regular tablets. They just have a feature of after swallowing, goes to the stomach, into the duodenum, they start acting on blood pressure within 15 to 30 minutes. So that's not as fast as you want to curb an attack, but if there is a problem with that, blood pressure goes up and then pain is prolonged through elevated blood pressure, captopril, clonidine are really good. Clonidine nasal drops, unfortunately, has not yet developed to this level of practicality, so that's I put it in brackets. When pain comes and hits the patient and is so stressful, it can also be good that there is a bit of sedation. It, of course, means that one has to withdraw and one has to rest, but that could be a very good management strategy. So I say for adjunct sedation, orally dissolving clonazepam is also really good. If there is, with stress eliciting also anxiety, then liquid lorazepam, another benzodiazepine, has by the book and for many patients has the highest impact on anxiety. It doesn't have that impact on pain like clonazepam has, but lorazepam for some patients is particularly good if anxiety is a outstanding clinical feature of the pain attack. And so bold compounding pharmacy, blue controlled substances, italics, it can be expensive or not so easy to get approval for this. Really important, not so many doctors in this business know about this, but it's so logical that pain comes in attacks, you need to do something quick, and swallowing a tablet won't do it. So here, this is a list of things to do against pain, against high blood pressure, and against accompanying stress and anxiety. Rapid-acting medications are available. They should be available for every patient, and many patients are just happy to have them, and they feel reassured, they feel more secure if they have these medications at home, if they have the medication in their pockets, in their bags, and when they travel, that type of medication is with them, is sort of their first-line insurance against being hit by this pain and being without armor, without a countermeasure that they can launch by themselves. So that knowledge is also very reassuring and important. So this needs to be part of treatment plans for every patient where there is a worsening or attack-like manifestation of the trigeminal pain or other craniofacial pain that comes in attacks and episodically. Okay, so now we come to regular meds, the cornerstone of medical management of trigeminal pain, glossopharyngeal pain. Medication that is taken regularly to keep pain levels at a more manageable, at a better quality of life level, so that we want to reduce, for example, if pain level is 6 out of 10 and want to get it down to below 4 as a measure, and from there even lower. The textbook recommends carbamazepine, oxcarbazepine as a regular is available as regular tablet or extended release. That's what many patients get prescribed in neurology-oriented pain clinics. There is a relative of it is eslicarbazepine, as the name says. So they are carbazepines, and they influence sodium channels in inhibiting sodium channels from allowing nerve cells in the pain circuit to be overactivated and to allow the pain to spike. That works, and I have come to use it as test medications, whether somebody is responsive to one of these. And then in purple and bolded, I have used lacosamide. And lacosamide is a sodium channel inhibiting medication that is more potent and has a much better safety profile than the above. So first more potent, and then also the side effect profile is just better. TMA to my estimate, which is based on more than 5,000 encounters. At Duke University in my 2 clinics, I did not find the time to summarize this, to write this up, because I was busy in my research lab. Now I'm with Regeneron, but in the meantime, a group, a facial pain, a trigeminal pain group from Barcelona has written a very nice article that is speaking to the effects of lacosamide. Lacosamide has also been used for trigeminal pain as an infusion, and that effect has been observed to be beneficial and very effective. So the record here is clear, and other people around the world have seen this. This is not just Dr. Littke placebo effect. This is real, and what stands out is that lacosamide is just way advanced in terms of how the medication is tolerated and side effect profile. That's that. So there's also sonnisamide zonegran, which is not as strong, not as potent, but has a profile of it's very well tolerated, and it can help patients lose weight. So zonegran, sonnisamide used to be sort of a secret weapon that we used in the Duke neurologic pain clinics, where there were a lot of patients with migraine, and some of them had an issue with elevated or way elevated body mass index. And so sonnisamide, zonegran was a helpful medication for these patients. And I list here the issue of low sodium that can be brought about by carbamazepine, oxcarbazepine, and that can get a patient and the treating team to hell because sodium goes down. And at one point when sodium in the blood goes down, that is also the sodium that surrounds the brain, the pain medication will stop working. And then pain will shoot up, and the drug is causing sodium to go down. Carbamazepine causes so-called SIADH. ADH hormone is secreted inappropriately because of carbamazepine or oxcarbazepine. Sodium goes down, and the drug stops working, and the pain goes up. And then patients take more carbamazepine, and sodium goes down more, and then they are in real trouble. They have a electrolyte osmotic emergency that could bring a patient to the intensive care, and they have exacerbating therapy refractory trigeminal pain. That can be really, really bad, a bad medical emergency that needs intensive care and perhaps like sedation or almost like general anesthesia to bridge it over. Lacosamide, sonnisamide are not as, they don't have that side effect to that degree. They elicit an SIADH at much, much lower frequency. Sodium channel inhibiting compounds, gabapentinoids, that's gabapentin and pregabalin. So pregabalin is Lyrica. Gabapentin is a generic now for most. And regular tablet, extended release tablet, side effect can be weight gain to a degree that the anti-pain effect is not really hitting home in a beneficial way. If you imagine pain goes down from 5 or 6 to, let's say, 4, 3.54, but patients gains 20, 30 pounds under Lyrica, which is extremely hard to shed. Where is the gain? So that needs to be calibrated carefully and can be a very good co-medication. And for example, I have treated patients with trigeminal pain after zoster who were not responsive to Lyrica, and they were not responsive to carbamazepine. But if you combine lacosamide with Lyrica at relatively low dose, that was a very good solution for these patients who did not respond to either medication alone. And trigeminal pain after zoster can be very, very recalcitrant and difficult to manage. Our next list, lamotrigine, which is also a very good anti-neuropathic and anti-neuralgic pain, originally a medication against seizure disorders. And the point with that is one needs to have a time course of several weeks because it needs very slow dosing in. So it's not suitable for wanting to quell and wanting to bring down pain rapidly. But if there is an option that something could be done on this time scale, and that would work with a patient, lamotrigine can be an excellent option. Because aside from a bad side effect on skin, which happens more frequently, is a side effect of burn-like, as if the skin is burned. So that side effect is facilitated when one uses lamotrigine rapidly, and is avoided when using it with very slow dosing in. So aside from that, lamotrigine is also a very safe drug. So finally, at the end of this page is baclofen and cyclobenzapril, which are different mechanisms of action, which are also being used in for trigeminal pain, and they have a feature of also relaxing skeletal muscle, and that can sometimes be quite toward the patient's situation, because there is chronic neck pain and chronic neck shoulder pain together with the trigeminal pain, or if it's a chronic neuropathic pain that started with a TMJ disorder, then these compounds that act on neuropathic pain and on muscular tension are quite helpful, which is baclofen at a dose of between 5 and 20 milligram, 2 to 3 times a day, or cyclobenzapril, 5 to 10 milligram, up to 3 times a day. Good combination medicines to combine with other approaches. Very suitable for muscular tension. Number one. Number two, the list goes on. There are SSRI, SNRI, NDRI, which means serotonin selective reuptake inhibitor, serotonin noradrenaline, or noradrenaline dopamine reuptake inhibitor. So these are medicines that act on neurotransmitters and make these neurotransmitters act longer in the central nervous system. And some of these medicines that come from mental health, from psychiatry, from mood disorders, and other psychiatric conditions have also found their way into pain medicine, such as duloxetine or Cymbalta. It is also a good mental health medication, but it perhaps is a better anti-pain medication than that, which it wasn't designed to be, but that was found through clinical use. So here we go between 30-60 milligram, 1 to 2 times a day. If duloxetine doesn't work, it's always worth to try venlafaxine, which is not very logical. Why would venlafaxine work if duloxetine does not work? But clinically, that's the case, and that's worth trying out. These are typically also combination medicines, and for example, combining duloxetine, Cymbalta with gabapentin has been a savior for a number of patients with trigeminal pain after zoster, post-herpetic pain. Again, very hard to treat, very difficult to treat, not responding to either medicine alone, but then you combine duloxetine with gabapentin or Lyrica, and it works. So going down the list, vortioxetine is a more recent addition to this panel with higher potency. Mirtazapine is good for normalizing sleep and can enhance weight. So if a patient has lost weight with trigeminal pain, that's very suitable then. But if there is an issue with enhanced and above 30 BMI, then mirtazapine is not so suitable. Milnacipran is a related medicine, but is heralded for use with comorbid fibromyalgia, and in those cases is worth a trial where duloxetine would be the first go-to, but milnacipran for fibromyalgia is perhaps a tad better. Last but not least, bupropion, that is an NDRI, so it also affects dopamine, and it can help with habitual disorder that interferes, such as if a patient with trigeminal pain has difficulty getting off cigarette smoking, or tobacco use, oral tobacco use, or drinking alcohol that is not good for the disease but cannot let off, bupropion will be very helpful. Bupropion can also help normalize weight, especially if that is in the context of something like obsessive eating. At least cannabinoid, because Marinol could be prescribed for a long time. That's pure THC. I have prescribed a lot, but my bottom line here is can be helpful as a third-line agent for some patients, certainly not for the majority who ever got it. Anti-inflammatories, I have listed here 2 of them. Indomethacin, one of the strongest anti-inflammatory medicines by inhibiting the formation of pain-enhancing prostaglandin. It shuts down the production of these pain-enhancing lipids totally. And with that, it can also cause stomach ulcers and stomach inflammation. It's very strong, but it has a particular feature on bringing down inflammation in the trigeminal system. So it has to be listed here. Temporary use, if it helps, great. Then perhaps for longer term use, if an anti-inflammatory is mandatory, meloxicam is the compound to use, because that has a selectivity for so-called COX-2, and COX-1 is the one that will damage the stomach. So meloxicam is much more gentle on the stomach and can be used long term. When starting with indomethacin, which is more powerful, is more punch. Okay, that's regular meds. And then we come to a specialty that I have one medication, one slide, that's low-dose naltrexone. Unique medication. Naltrexone is a blocker of opioid medication when used above 50 milligram per day, approximately. And so it is dosed between 1 and 5 milligram, 1 and 4.5 milligram, up to 6 milligram. That's called low-dose naltrexone. So for that, it's not the classic opioid blocker. And it has 2 things that it does that we sort of know. First, it gently kicks on the endogenous opioid system. And then if it's done in the right synchrony with the circadian rhythm, it enhances the endogenous opioid system while the patient sleeps. That's number 1. So it's an endogenous opioid enhancer by gently blocking it. And if you do it in the right way with the circadian rhythm, it makes it the system go higher during sleep. And if that happens every night, that's good. That is indeed very helpful. Second, together with it or synergizing with that is an effect on glial cells, which are other neural cells that support and that make nerve cells function the way they do. And the glial cells can also make nerve cells malfunction the way they malfunction, for example, in chronic pain. So calm down glial cells, for which there is no medication at this point, but low-dose naltrexone might be the only one. So it does these 2 things. Perhaps it does more things that we don't know. And it is a opioid blocker medication with the lowest formulation dose of 50 milligram per tablet. So it has to be compounded. You have to go to a compounding pharmacy and ask for low-dose naltrexone in that strength. 2 milligram or 4.5 milligram is a standard doses for supporting trigeminal pain therapy. It's not an analgesic. So if a patient starts taking low-dose naltrexone, essentially nothing will happen. In low-dose naltrexone, monotherapy is not suitable to manage trigeminal pain. But to add low-dose naltrexone to a regimen has changed many lives in my hands, and it has a convincing argument that it is very, very safe. In clinical studies where it was used with fibromyalgia patients, with rheumatoid arthritis patients who also were helped with their chronic pain, it has a side effect profile equivalent and similar to placebo. That's very convincing to me. And like that, I have prescribed it to a lot of people, and it has changed a lot of lives. For example, the combination lacosamide plus low-dose naltrexone. That's just a great combination. Some patients are sensitive to even low-dose naltrexone, and in that case, I have divided the dose by 10 and given them 0.1 to 0.75 milligram per day, so-called ultra low-dose naltrexone. Worth it if a patient cannot tolerate the regular low-dose naltrexone. And in that case, I have always suspected, or in those cases, I have suspected comorbidities from an autoimmune spectrum type of disorder. Okay, suggestion. Low-dose naltrexone could be used after surgical or invasive treatment like microvascular decompression or stereotactic radiosurgery to prolong the interval until pain comes back. And that would be a clinical study that I find highly meaningful for future for the future to be implemented. And that is something that perhaps we should discuss, how facial pain association can be helpful of making such a study work, because low-dose naltrexone is not endorsed by a major pharmaceutical company that produces it. It's made by compounding pharmacy, and essentially there's not a lot of money and profit that is made through it. And that has, as a side effect of that, is that a clinical study is hard to find to be underwritten. Nasal sprays, also as a regular interval that I list alongside with low-dose naltrexone, is oxytocin nasal spray and ketamine nasal spray that can be taken. And for oxytocin, I have encouraged patients to take it 5 days a week, 2-day drug holiday. And with ketamine, also daily use has been found a good management strategy for some of my patients, but that also needs to be applied in a way that there are drug holidays, so that the effectiveness of the medication can be contained. Okay, so that is regular med 3. Now regular medicine 4, we come to the effects of CGRP, which is a critical driver of migraine pain, and there have been CGRP medications developed that block this peptide. So it's a small fragment of a protein. If you inject that under the skin of a human, they will feel pain. If you inject it into an animal, they will see the pain behavior. If you inject somebody with CGRP who's a known migraineur, they will develop a migraine attack. So if you use medicines that block CGRP, you can reduce the frequency of and severity of migraine attacks. And there are self-injected anti-CGRP, so-called anti-CGRP monoclonal antibody of galcanezumab, fremanezumab, erenumab, that is patient self-injection once a month. And there is one that we talk about for intravenous use in clinics. And these doses that are listed, they have been found effective and appropriate for migraine. And perhaps here that patient with trigeminal pain need higher doses, whereby galcanezumab is FDA approved for cluster headache, which is a very nasty form of a headache, also mediated through the trigeminal system. So a cluster patient needs 300 milligram, not 120. And something like that could also be true for trigeminal pain. However, it will not be easy to find doses of these medications approved by the insurance plans higher than what I listed here. So I have prescribed them for my patients under a banner or under a headline of migraine comorbidity, and then we treat the migraine with galcanezumab, and there is migraine and comorbid trigeminal pain. For insurance purposes, that is needed, or to approach the companies for compassionate use and ask for these drugs to be available essentially free of charge for compassionate use. But that compassionate use is not a very high likelihood way of implementing such a treatment. But so clinical observation here is that these can be good to very good supplementation of a medication plan, and patients are doing better when they self-inject with these medications, and patients ask for continuations with these treatments. In some patients, it takes up to half a year for full benefit. Some patients know that this is working for them within 2 to 3 weeks. But if it does not work with the first round of injection, that does not mean that the patient is a non-responder. And I have practically limited that to 3 months of injection, and have the patient make a call whether after 3 months they say, well, this is helping or not. If not, then discontinuation. Okay, opioids should be mentioned because patients with trigeminal pain disorders are taking opioids. So we have low potency opioids, hydrocodone, oxycodone, tramadol. And bottom line here is, if helpful, can be used under the appropriate guiding principles. But first, you take opioids, you cannot take low-dose naltrexone. That's a serious consideration because low-dose naltrexone is that good. But there are patients who they have to take a low potency opioid, otherwise they have no life. So in that case, how is it managed successfully? It's all doable because we can do drug holidays to maintain the susceptibility of the endogenous opioid system, aim for an opioid rotation to maintain susceptibility. Of course, opioids cannot be used if the patient has a liability to become addicted. However, I have managed hundreds of patients with low potency, low dose opioid use over many years, and have managed them very successfully without any violation, without any transgression, without development of any addictions. And so that's something that is perhaps a dirty secret of the pain treatment world, but it is absolutely true. So there is a across-the-board phobia for combined treatment of low-potency opioids with orally dissolving clonazepam, because then it's an opioid, and the opioid can kill you, and then you use a benzodiazepine together with that, and it makes a respiratory arrest even more likely. That is also not a very serious argument, because so low-potency opioids are what they are. They're low potency, and they're given at a dose that is sort of balancing it. And then orally dissolving clonazepam is 1/10 of the dose of the tablet. Okay, so still left with significant pain. Long-term management would be with methadone. That's a practical solution because inexpensive, can be readily prescribed, does not induce euphoria. The other butorphanol, levorphanol is not as prevalent or is not as practicable as methadone. Fentanyl patch for opioid rotation to maintain feasibility. But I would advocate long-term use with methadone in the first place. Maybe the future will hold that there will be modified opioid treatments, as I have explored in this research study together with colleagues from China. Okay, fight comorbidities like, as much as you can, vigorously fight comorbidities which are listed here. Perhaps as an update toward last year's presentation, the obesity comorbidity with semaglutide, tirzepatide is cranking up and is becoming more prevalent use. And I would gamble some money that if one reduces BMI, that makes trigeminal pain better. And reducing BMI can be extremely hard. I know from trying to practice that together with my patients for many years. And so these new GLP-1 RAs and GLP-GIP RAs, they like semaglutide, tirzepatide, that could be a way to get the critical inroad that then leads to pain is better, BMI goes down, patient can start exercising, which they want to do anyway, but they could not because of the trigeminal pain. Okay, so this slide it hammers home, and I have practiced that a lot over the years. Examples here, comorbidities of benign brain tumors, of orbital tumors, of dental issues that were in need of repair. Comorbidities, fix them. Find a clinical setting where this can be fixed. That cannot be fixed one day to the next. It takes a dedicated team to do this. Okay, we come to intravenous. Those are sodium channel blockers. Lidocaine, phenytoin block sodium channels, can be infused in the emergency room, urgent care. Corticosteroids, also for urgent care, emergency care, but also for intermittent pulse therapy at that high dose, 3 to 5 times per week, and then once a month, and for longer term use, 3-4 times a year or twice a year, has a effect on trigeminal pain. And after one round of this type of a medication, the patient knows whether this is acting, is very effective against all forms of inflammation, and has also a direct effect on the trigeminal pain system at that dose. Meloxicam can be infused intravenously. There is no intravenous aspirin in the United States. 30 to 60 milligram for a short-term infusion works more powerful than the tablet. And here is an intravenous anti-CGRP like galcanezumab, fremanezumab, erenumab. It's called eptinezumab. That patient's report also has effectiveness when the self-injection under the skin is not working. Okay, this is a new slide over last year's presentation. There is a nutraceutical palmitoyl ethanolamide that, when given together with Lyrica and nortriptyline at low dose, was helpful to patients who got trigeminal neuropathic pain after extraction of a tooth. And it was a randomized, placebo-controlled, double-blinded clinical study from India in a very small number of patients, only 20 patients, but the effect of palmitoyl ethanolamide when added to the medication was quite significant. So it's a nutraceutical, and I'm not talking about nutraceutical, but I see here the nutraceutical was used in a proper way to combine with existing neuropathic medication in a double-blinded study, and the results hit home. So I wanted to share this with the audience and make that available. Palmitoyl ethanolamide, PEA, P is available over the counter. It's not a prescription medicine. So that's, again, slide from last time. It needs a winning team. If you watch the NBA, you can see some winning teams where you see that, team is team. It makes over, individual artists on the other side. And that's what it takes to come up with lasting and effective solutions against trigeminal pain. FPA is a great partner to help build these teams. And there is still room for a lot of improvement in many places to have these winning teams that truly help patients in place. Okay, so I think with this I stop. This is a piece of science where we have found that why is trigeminal pain different from pain of the body, that it has a direct wire to emotional processing center in the brain, published Nature Neuroscience 7 years ago. It's a new wire in the brain that we discovered, nothing short of that. So why is that wire not being used as a target? Maybe it will. Never give in. Be Spock. You're not alone. And with that, I'm ready to take your questions.
Thank you, Dr. Lika. Wonderful information. Really appreciate it. We have a ton of questions, so we're going to get right to that.
Going.
Yes.
Should I stay in the share presentation or get back to the WebEx?
So there are certain medications that play well together with fewer combined side effects, or some that work better to target type 1 versus type 2 TN?
So the sodium channel blockers classically have been viewed as being very effective against a neuralgic manifestation, and the gabapentinoid and the medication that act on neurotransmitters like SSRI, SNRI have been viewed as being the first choice for neuropathic pain, for chronic pain that is not characterized by pain attacks. So lacosamide is a medication that beats that, in that it is very effective. It can bring attack-like trigeminal pain to zero, as can carbamazepine. But lacosamide, remember, it is more potent, and it is also more safe, way more safe. And lacosamide can also have a beneficial effect on neuropathic pain, whereas carbamazepine and oxcarbazepine rarely have. The gabapentinoids, on the other hand, very good choices, first level choices for neuropathic pain. But then there are patients with neuralgic pain who just are managed better with gabapentin. So I think the clinical reality and the use of this medication in clinical reality blurs these distinctions.
Great, thank you. Next question. What medicine is recommended for anesthesia dolorosa caused from MVD surgery?
Yeah. So anesthesia dolorosa is always caused. To my knowledge, there's no anesthesia dolorosa that happens out of the blue sky. There has to be some form of injury to the trigeminal system, which typically is iatrogenic, which is a nice term, essentially at the receiving end by what the doctor does. Iatros, Greek, the doctor, iatrogenic. And that is why many doctors don't like it, because it was done by a doctor and you don't bite your own kin. So very difficult territory where I had a discussion with Melissa, who heads the FPA, that this is worth a dedicated sub seminars and sub attention. Bottom line, simple answer, nutshell answer: no single medication will do the job with anesthesia dolorosa. It will be a dedicated mixed regimen whereby different components will contribute. And I have, for example, given an example, been able to manage patient with anesthesia dolorosa with a combination lacosamide, low-dose naltrexone, and injection of botulinum toxin. or lacosamide plus low-dose naltrexone and monthly corticosteroid infusion. So, and I have, for example, also, let's say lacosamide, low-dose naltrexone, vortioxetine, and a neurostimulator to the forehead if the pain was in the first branch. So combined approaches of that kind.
Okay, thank you. Next question. How do these medication suggestions change for trigeminal neuropathy T1, T2? This is kind of like a little bit more like the question we had before, but can you expand a little bit more?
So what was it? The overlapping conditions, or when the condition is treated and then the attack-like pain goes away and leaves the neuropathic pain as the only one behind, or what was it alluding to?
Let me try to see. I think, how does it change between T1 and T2 with these suggestions of medication?
Yeah, so a pharmacological profile that's one thing, the phenotype of the pain, the patient describing the pain very well, and the doctor can elicit that, and then one has a very good description of the pain, but then one also has a response of the patient's pain to pharmacologic intervention. And the patient will say, I like gabapentin the most, and next to it, I like Cymbalta. However, carbamazepine, I don't really know, because the moment I take it, I start vomiting. So that's sort of that patient's profile. And the profile matching the description has some probability of this, like episodic pain attacks responding to block of sodium channel. And chronic pain, not so effective with the classic sodium channel blockers. But then, as I say, lacosamide is the one newer drug. And remember, it's like about 20-year-old drug. Whereas carbamazepine is about 60-year-old or 50-year-old. So lacosamide beats that in that it can also be quite effective against neuropathic pain. And that is one example where this entire idea of, sodium channels, episodic pain, and in other ways chronic pain goes, that's for neuropathic pain. Well, sodium channels appear to be also involved in neuropathic pain, and that's, for a pain researcher, it has never surprised me. It has perhaps says something about these older drugs, that they have more limitations.
Okay, great, thank you. I think we have time for maybe one or two more questions.
Okay.
What did you do to help the patient with an iron injury?
What type of injury?
IAN injury.
Inferior alveolar nerve. Okay, that was a gentleman who broke the jaw after a failed dental implant, broke the jaw, then the bone got infected. And so we first treated him together with the dental faculty at University of North Carolina, Chapel Hill, and we restored stability to his jawbone, because nobody touched it and said, you're hurting so bad, it might heal by itself. No, it didn't, because it was infected and was not stable. So we gave him higher doses of opioid and then repaired that jaw with screws and metal. And then the jaw healed and he got stability in the jaw. And we also treated him postoperatively with higher doses of steroids so that the nerve could not swell while the bone was healing. And at that point, then he was subjected to a combination treatment that had as a mainstay Lyrica and methadone. So he was on Lyrica plus methadone, low-dose methadone, and medium-dose Lyrica. And every 3 months, he came to my office to be injected with Botox. And that it went on, and slowly he got better. So that methadone was prescribed as a liquid, which I became a big fan of, because it doesn't restrict you to the tablet, like 5 milligram, 10 milligram. You can do 4 milligrams, 7 milligram, whatever, with a liquid. And so we could see that the liquid methadone, he reduced and reduced and reduced. Well, I don't fully remember whether he was on some type of like super minor 2 milliliter methadone 2 milligram methadone or whether it was all over. I think it was he needed like 2 milligram methadone when he had more stress, and when he was all out on vacation at his beach home, he didn't need it, and that also made a lot of sense. So he was managed with a combination treatment that also included in the first place the surgical repair of the broken jaw, and then careful management of postoperative period analgesia and adaptive analgesia that then in the end led him to reclaim his life.
Great. All right, we'll do one more question.
Yeah.
If we are already on carbamazepine. Thank you. Daily dose. Is it safe to take these fast acting on top of our normal daily meds?
Yes, it is. So if you have a baseline medication with carbamazepine, oxcarbazepine, then you take chewable carbamazepine on top of that. You add to the daily dose, and that could lead to a territory of a mild carbamazepine high dose effect. And carbamazepine high dose effect is essentially the effect of being drunk minus the effect of alcohol on your brain's cortex. So, alcohol being inebriated also disinhibits you, makes you feel giddy, etc. Carbamazepine does not do that. Carbamazepine can impair coordination and can make you nauseous, like being overly drunk can do. That's the effect that you get when you go up with carbamazepine. But if that's the territory you get into while at the same time bringing this pain under control and shelving or putting into the box the imminent attack of a major trigeminal pain attack, patients typically say that choice is very clear. I have that little bit of uncoordination and feeling dizzy. If I'm certain that my pain will be boxed up. So that it goes to how the patient feels. A way out would be to use other fast-acting medicines that are not carbamazepine, like use 50 milligram or 25 milligram chewable plus that clonopine, those two things together, or ketamine nasal spray for that matter, which will not add to the carbamazepine toxicity. And that's the principle of so-called polypharmacy, that you add several things in parallel, and the several things in parallel will all have an arrow on the pain and will diminish pain, but they will not share the same side effects. And so therefore the intersection of that for effect is anti-neuralgic, anti-neuropathic, but the side effect profile is diversified and therefore it doesn't manifest. And that is true also for this fast-acting therapy where you have carbamazepine and clonopine. They have different toxicities, and therefore that combination is good.
Great. Thank you. So that will be our last question. We come to the end of today's session. Dr. Lieke, this was wonderful. We really appreciate all the information you've given. And just a reminder to everybody that the questions that were not asked in the live session, Dr. Lieke will answer them, and it'll be available when the record sessions are available. Also, we'll be transcribing sessions, and that will be available as well. So we have about a 30-minute lunch break scheduled before Dr. Jeff Fogel starts his talk at the top of the hour. It's 2 p.m. Eastern Time, 11 a.m. Pacific. Dr. Scott Morrow started her talk about 15 minutes ago. All sessions are being recorded, and you can see them in their entirety. But if you want to view it live, you're more than welcome to go back to the agenda and then click on that session. Thank you so much, and have a good rest of your day.
Bye-bye.